The test item cluster for mechanical neck pain likely to benefit from thoracic manipulation includes symptoms less than 30 days, no symptoms distal to the shoulder, looking up does not aggravate symptoms, FABQ score for physical activity less than 12, diminished upper thoracic kyphosis, and cervical extension range of motion less than 30 degrees. All right, Elise, I'm going to have you look up for me. Good. The test item cluster for full thickness rotator cuff tear includes the drop arm sign, where the examiner abducts the arm to 90 degrees and asks the patient to slowly lower it to their side. The painful arc sign, where the patient abducts their arm through the full range of motion and the examiner notes any pain within that motion. The infraspinatus muscle test, with the patient's arm at their side and the elbow flexed to 90 degrees and medially rotated 45 degrees, the examiner applies a medially rotated force that the patient resists. The test item cluster for subacromial impingement syndrome includes the painful arc sign and the infraspinatus muscle test, which were previously demonstrated, along with the Hawkins-Kennedy impingement sign, where the patient forward flexes their arm to 90 degrees and the examiner applies a medially rotated force. The test item cluster for patients with mechanical neck pain likely to benefit from cervical manipulation include symptoms less than 38 days, expectation that manipulation will help, cervical rotation range of motion difference of 10 degrees or more between sides. Go ahead and rotate to your right. Good. Go ahead and rotate to your left. Good. And pain with posterior to anterior testing of the cervical spine, where the patient lies prone with a pillow under their chest so the head and neck are in a neutral position. I'll place the tips of both thumbs over the spinous process of targeted vertebra and apply a gentle posterior to anterior force to assess pain, mobility, and infeel. The test item cluster for cervical radiculopathy includes less than 60 degrees of ipsilateral cervical rotation, a positive Sperling's test, where the patient side bends their head to the symptomatic side and overpressure is applied. A positive distraction test, where the patient's head is cradled and a distraction force is applied. And a positive upper limb tension test A for the median nerve. The patient's arm is abducted to 90 degrees, the scapula is depressed with the thigh, the patient's forearm is supinated, elbow flexed at 90 degrees, and the wrist and fingers are extended, and then lastly the elbow is extended slowly. The upper limb tension test 2B for the radial nerve. The examiner abducts the shoulder to 10 degrees and uses their thigh to depress the scapula. They then pronate the forearm, medial rotate the shoulder, flex the elbow to 90, and flex the wrist and fingers. Then the elbow is extended. The patient is asked to report any symptoms throughout the test. You can sensitize this test with contralateral and ipsilateral cervical lateral flexion. The differential diagnosis for rotator cuff tear versus C5-C6 radiculopathy is as follows. For C5-C6 radiculopathy, you would see a positive shoulder abduction test. Go ahead and raise your hand over your head. Good. I would then ask if this changes the patient's symptoms in any way. You would also see a positive distraction test, a positive upper limb neurotension test, a positive Sperling's test, and a negative Hawkins-Kennedy sign. You would also see limited cervical rotation range of motion to the ipsilateral side, possible numbness and tingling in the C5-C6 dermatome, possible weakness of shoulder internal rotation, elbow flexion, and wrist extension, diminished C5-C6 reflexes, specifically the biceps and the brachioradialis. For a rotator cuff tear, you would see a positive infraspinatus muscle test, a positive drop arm sign, where the patient can only control the movement through part of the range of motion, a positive Hawkins-Kennedy test, a negative distraction test, a negative upper limb neurotension test, a negative Sperling's test, and you would also see normal reflexes and sensation. All of these tests have been previously demonstrated. The load and shift test. The load portion is done by grasping the humeral head and positioning it in the glenoid fossa. The shift portion is done by pushing the humeral head anterior and posterior, noting the amount of translation and infield. You should compare bilaterally to determine atraumatic instability. The active compression test of O'Brien is used to detect superior labral tears. The arm is flexed to 90 degrees and abducted 10 to 15 degrees and medially rotated so the thumb is down. The examiner then applies a downward force that the patient resists. The arm is then supinated so the thumb is up, and the examiner applies the same force. The liftoff sign is a test for subscapularis muscle strength. The patient turns and places their back of their hand on their back pocket. They then lift their hand away from their back, and if they're able to do this, the examiner applies a force towards their back pocket. The supraspinatus or empty can test is used to detect supraspinatus tendon pathology. The patient's arm is abducted to 90 degrees with the hand in neutral, and a downward force is applied. The arm is then moved into scaption and medial rotation so the thumb is pointing down in the empty can position, and the same force is applied. Still going.